All right. Hello, everyone, and welcome to the first webinar of 2023. Thank you for joining us here in the middle of January. Today, I'm going to walk through the state of Minnesota stroke care. And for those of you that attended the Minnesota Stroke Conference, much of this is repeated information. We did think it would be valuable for everyone to have the opportunity to hear this information and thus decided to share it again with you all today. I'm also delighted to be joined by our evaluation specialist, Mimi Amalang, later into the presentation. She'll be talking about the hospital inventory survey and results. Seasoned coordinators are very familiar with the hospital inventory survey. And for those of you that aren't, it's an annual thing. So you're definitely going to have the opportunity to complete it later this year. All right. So we'll get started with some program announcements here. The QI Awards Program webinar was last week, and once again, we want to congratulate this year's award winners. Please check out our website for more information on the 2023 program, in addition to checking out the display of this year's award recipients. February is Heart Month, and there's so much overlap between health and brain health and stroke, and many of you wear multiple hats working across programs. Our webinar next month will feature work in the cardiovascular space, and we hope that you'll join us. Stay tuned for that calendar invite and for more information at a later date. Please continue to notify our team here at MDH by the health.stroke email address for any program contact changes. Additionally, you can email any one of us individually, and we'll take care of updating those resources here. And then lastly, our Designation 4.0 documents are available officially now on the website. For those of you due to apply April 1st, you have likely heard from Michelle Gray-Ansari this week with a reminder email as well, and those resources were sent directly to you. Please reach out to Michelle or myself if you have any questions along the way. Few other housekeeping items. This webinar is part of our MDH Stroke Program Monthly Education Series. Stay tuned to your email for a different educational opportunity each month. As mentioned, this webinar is being recorded, and you can access all previously recorded webinars on our MDH YouTube playlist. Your lines have been muted upon entry to the webinar. Please ask questions by typing them in the chat throughout the presentation, or hold them until the end. We do have some time for a Q&A. And if we come to that point where we can't get to all of your questions, we will certainly make sure to address them in the follow-up email. All right, our agenda today is just a mini state of the state data overview, as well as highlights from the 2022 EMS and hospital inventory surveys. The objectives for today are, upon completion, learners should be able to understand current stroke hospitalization and death rates in Minnesota, summarize current performance for the stroke-specific measures in the statewide quality reporting and measurement system, also known as SQUIRMS, and describe results from the 2022 hospital and EMS inventory surveys. Contact hours will be offered today, a 0.5 contact hour, so stay tuned at the end for that evaluation link that gets dropped into the chat to complete the survey to claim those hours as well. All right. So nationally, stroke is the 5th leading cause of death. And of the 795,000 strokes annually, roughly 137,000 people die. Presently, stroke is the 6th leading cause of death and one of the leading causes of disability in Minnesota. The pattern of stroke deaths has remained relatively steady otherwise over the last decade. And provisional data for 2021 shows a slight increase in deaths in 2021 from 2020. When we look at stroke death rates, Minnesota's stroke death rate is about 17% lower than the United States average and is tied for the 11th of the 50 states in the District of Columbia. So this map displays stroke mortality by state from 2020. And the darker the color or shade of blue, the higher the age-adjusted death rate. So lowest stroke death rates nationally are in the state of Massachusetts. The worst performing state is Mississippi, which likely comes as no surprise, as Mississippi sits within the well-established stroke belt. Minnesota is tied for number 11 with North Dakota. Our other bordering states are shown here, with only Iowa having a lower stroke death rate than Minnesota. We know that disparities exist in death due to stroke. In Minnesota, Asians, Pacific Islanders, African Americans, African-born, and American Indian Minnesotans die at rates approximately 40% higher than Minnesotans overall. Latinx Hispanic Minnesotans have the lowest stroke death rates. And these disparities in deaths are rooted in inequities that have persisted in the United States and Minnesota for many years. So now we'll talk a little bit about stroke hospitalizations. The long-term decline in stroke hospitalization rates is limited to adults age 65 and older. Adults younger than 65 have experienced slight increases in hospitalization rates between 2005 to date. Make note that in 2020, stroke hospitalizations were down more than 10% from 2019, which aligns with what we witnessed during the early stages of the pandemic, thus resulting in a decreased rate. We are working on updating these data and we'll have it available in the coming months on our cardiovascular health dashboard. And we'll share those links once the 2021 hospitalization rates have been updated. When we took a look at a recent age-adjusted hospitalization analysis stratified by race in Minnesota, this data demonstrated that non-Hispanic Native American, non-Hispanic Asian, and non-Hispanic African Americans experienced the highest stroke hospitalization rates in Minnesota. Additionally, these data were further broken down by age. And here, I only included what is typically considered a younger stroke, which is those 35 to 64. And this demonstrates that non-Hispanic Black and African American, non-Hispanic American Indian, and non-Hispanic Asians are experiencing stroke hospitalization rates at higher rates than others. And another thing to highlight is that non-Hispanic Black and American Indian adults age 45 to 54, their stroke hospitalization rates are more than double that of groups with lower rates. In the 55 to 64 year range, the hospitalization rates are nearly 3 times higher for non-Hispanic Black and American Indians. So you guys know one of the principal cornerstones of our program work and your program work is quality improvement. And the Minnesota stroke system has evolved from the beginning and addresses the entire spectrum of the stroke experience, from prevention to recovery. And a primary goal is to ensure that all acute stroke patients receive the highest quality of care possible. The stroke system evolution is one example of the impact of quality improvement work. In 2012, only 60% of Minnesota's population lived within 30 minutes of a designated stroke center. To date, there are 116 designated stroke hospitals, including 13 comprehensive stroke centers, 10 primary stroke centers, and 93 acute stroke-ready hospitals. This means 92% of Minnesotans now live within 30 minutes of a designated stroke system hospital, which is an increase of 1.8 million residents with access over the last 10 years. Many of you are familiar with the SQUIRMS stroke measures that were developed many years ago. There are 2 reported measures for stroke, door to imaging and door to needle. Listed here on this slide are just a few of the exclusions for the door to imaging SQUIRMS measure. For a full list of this exclusionary criteria, please check the website. But first, we're going to look at how door to imaging within 25 minutes, how that measure has been over the last few years. So you can see here demonstrated that there have been improvements over time, and this measure has remained relatively steady. I will point out in 2020, we saw a large drop in the number of patients who were eligible for this measure, down 15%, which definitely seems to align with observations that fewer sought emergency care for stroke signs and symptoms during that year. In 2021, we saw an increase in eligible patients for this quality indicator, meaning more patients with stroke signs and symptoms were coming to the hospital sooner. We hoped as we enter this new state of normal and as we look at 2022's data, it continues to stabilize. This slide depicts the door to imaging SQUIRMS measure separated out by designation status. And you can see that non-designated hospitals perform worse on this measure than those that are not designated. As well, in most recent years, acute stroke ready hospitals have outperformed primary and comprehensive stroke centers in Minnesota specific to this performance measure. The next SQUIRMS measure is the door to needle metric. And this includes all ischemic stroke patients, but again has a clean list of exclusionary criteria. So this slide only has a few outlined, but again, that complete list is available on the website. And, okay. All right, so in 2020, we saw the highest performance on this measure since we've been collecting these data, with 76.5% of patients started on IV thrombolytics within 60 minutes of arrival. We do note, though, that fewer people received this therapy in 2020 compared to the previous 4 years. Again, we saw that fewer patients came to the hospital for stroke, and of those that did, fewer arrived within the treatment window, so they were ineligible to receive this therapy. In 2021, we saw an increase in eligible patients once again for this quality indicator, and an improvement in those meeting this metric as compared to a non-pandemic year like 2019. The number of patients meeting this goal has shown slight improvement over the last few years, but there are differences between hospitals designated as primary or comprehensive or acute stroke ready hospitals and hospitals who have yet to receive designation for their stroke care. In the spirit of treatment, let's talk a little bit more about the landscape of thrombolytic treatment and what that looks like in Minnesota. So since 1996, Alteplase has been FDA approved for the use in stroke patients. It's since been the only medication choice for treatment of acute ischemic stroke. That was until the updated guidelines were released in 2019, indicating tenecteplase as an option for select patients. What we know about tenecteplase, it's easier to administer, it can facilitate faster treatment and transfers, it's cost effective, and it most certainly has simplified the handoff for transport with EMS. In the SQUIRMS measures, we mentioned that fewer people received thrombolytic therapy in 2020 compared to the previous 4 years. SQUIRMS has that, again, clean list of exclusionary criteria. So for this slide, we took a look at the percentage of ischemic strokes treated with thrombolysis overall. In 2021, we had the highest volume of total ischemic strokes and the second highest number of treated patients. We continue to perform really well as a state overall. In an ideal world, though, we'd see less strokes and more patients arriving within the treatment window. Thrombectomy treatment has steadily increased over the years. In 2020, there was a slight dip in total strokes, as mentioned before, as well as those treated with thrombectomy. 2021 appears to be more stabilized, although noting again, the highest overall volume of ischemic strokes we've ever seen was in 2021. As you all know, stroke is not isolated to the older population and can in fact happen to anyone. There are some concerning trends that are worth mentioning. Stroke death rates have increased by over 10% in ages 55 to 64. And in this same age range, Black and American Indian adults are hospitalized at rates nearly 3 times higher than others. And looking at what we would consider younger strokes that are less than 55, these folks are less likely to arrive via EMS, which potentially contributes to delays in CT and delays in treatment times. So where are we going next as a program? This is our 2023 update, right? Designation 4.0 is here, which means the stroke system legislation has been in place for 9 years now. Our CDC-funded activities have shifted from establishing a stroke system of care to the prevention arena and working with those at highest risk for stroke events. This time next year, our team will be thinking about the next round of funding, reaching out to partners, and see where the work will lead us. It'll be extremely exciting. So 2023 is going to be a great year. And thank you for everything that you're doing for your programs and for your community. This is just a quick update, a picture of our stroke team here. Please, at any point, feel free to reach out to anyone on the team directly if you have questions. Once again, another way to get a hold of us is to email that health.stroke inbox. The entire team has access, and we triage questions from there to the right staff person. Thank you for joining us today, and from here, I'll hand things off to my colleague, Mimi.
All right. Hi, everyone. My name is Mimi Ameling, and I am the Evaluation Specialist for the Minnesota Stroke Program. As Nikki mentioned, I'm going to share some highlights from our EMS and hospital inventory surveys conducted in 2022. So a little overview, these are annual surveys that are really designed to give us a systematic and statewide update on the latest in stroke care and what's happening with stroke programs in Minnesota. And they also inform our performance measure reporting up to CDC, our national funder. So these results are really important for us, both in terms of understanding what's happening across the state and where we can best support you, but also in being able to fulfill the requirements that allow our program to continue running. So we really, really thank everyone who responded to the surveys in 2022. We really appreciate your responses, and we have huge response rates. So we heard back this year from 59% of our EMS agencies and 89.5% of our hospitals. Those rates are pretty unheard of in the world of surveys. So by way of reminder, if you're someone who completed the survey this year, they were distributed in August 2022. The questions covered the previous 12 months, and the surveys covered a number of different topics, but I'm going to focus today on QI in hospitals and EMS agencies, some questions related to health equity, and then to NECTA-place uptake in our hospitals. So starting out with hospital QI, we found that 76% of our stroke programs started or completed a QI initiative in the last year. So that's great to see that the overwhelming majority of our programs are working on QI each year. In terms of which categories these projects addressed, key stroke metrics were the leading, followed by documentation in the medical record, the stroke code activation process, and then implementing or improving telestroke processes. Of those 84 hospitals that started or completed a stroke QI initiative, 69 or 84% actually changed stroke care practices as a result of that QI work. And those changes really line up with those same categories in the previous slide. So addressing documentation, key stroke metrics, the stroke code activation process, and telestroke. Finally, we saw that 66 or 83% of our hospitals that worked on stroke QI in the last year actually saw improvement in a stroke performance measure. So this is really cool to see so many of our programs kind of going full circle here. So starting or working on a QI initiative, making a change in practices or protocols, and then seeing that pay off in a performance measure improvement. And which performance measures improved? So by and large, it's our door to measures. We kind of lumped them all together for purposes of this survey, but we also had 20% of our respondents say they saw an improvement in their dysphagia screening, which is great to see. We have been talking quite a lot about this topic with our PSC and CSC hospitals in the last year. So hopefully we will continue to see some growth in that area. So in terms of EMS agencies, so about a third of our EMS agencies started or completed a QI initiative related to stroke in the last year. And that's very impressive considering that we know our EMS partners have many other, topics, situations, and health conditions that they address and need to be ready to address in addition to stroke. So we're pleased to see this. We're also pleased to see that 25 of those agencies made changes to stroke care practices as a result of QI. and then 31 actually saw improvement in a stroke performance measure. So these were exciting numbers for us to see this year. Turning now to Tenectaplace. So Nikki kind of previewed this in her presentation. In the survey this year, we really wanted to get a sense of how many of our hospitals were either already using Tenectaplace or planning to switch over to it. And we saw that the overwhelming majority of our hospitals are already using Tenectaplace, so that's 76%. And then another 20% are planning to switch to it in the near future. So we really see that Tenectaplace has become the primary thrombolytic agent here in Minnesota. So finally, coming to our group of health equity questions. If you took the survey this year, you may have noticed this new block of questions, kind of a new topic for us to be asking you about. And this really reflects a few different things. It reflects the changing focus of our CDC funded work. It also reflects the mission, vision, and values of MDH as an agency. And it also reflects the fact that, we as a stroke program team do really believe that health equity as it relates to stroke risk factors, stroke care, and stroke outcomes are really important things for us all to be thinking about and working on. So we asked whether stroke programs are reviewing their data broken down by patient demographics. So that would be things like race, ethnicity, insurance, maybe preferred language or primary language. Only 8 of our hospitals are currently doing this type of stroke data disaggregation, but 30% were interested in doing so in the future. In terms of which measures they're looking at, again, we see a lot of the door-to measures here being disaggregated, but also stroke education, thrombolytic therapy, and then all those SDK measures remaining kind of coming in fairly evenly. Our hospitals are using a number of different tools to do this disaggregation. For the most part, get with the guidelines, but also EHR reports, their own spreadsheets, and then 12.5% were using a tool in the Minnesota Stroke Portal, the Performance Improvement Case Review Report. We asked whether stroke programs are referring patients to other resources to meet their medical, social, or functional needs. So this encompasses quite a lot. It could be referrals for, post-stroke recovery, medical recovery, but also things like housing, perhaps food support. So we found that just under half of our stroke programs are making these types of referrals to clinical or community services, and community health workers or community paramedics are the most commonly used resource to make these referrals. 36% of these hospitals were using the resource facilitation program, which is great to see. They're also one of our partners on our stroke work here at MDH. Finally, we asked if stroke programs were currently working on any initiatives or activities related to health equity, and 11 of our stroke programs, or 10%, said yes. We asked these hospitals to tell us a little bit about those initiatives, and I've kind of lumped them into some main categories here. So we saw several related to doing stroke awareness campaigns targeted to specific populations in the communities that the hospitals serve, translating materials and resources into different languages to best serve the stroke patient population, improving interpretation services, tracking data for specific patient populations, as well as participating in larger hospital diversity, equity, and inclusion initiatives. So thank you to the hospitals that shared a little bit about their work in this area with us. We look forward to learning more and perhaps learning from more of our hospitals about work you might be doing or thinking about doing. I'll also put in a plug for the 2023 QI Awards here, which will have a health equity component. And so there may be some overlap in some initiatives that may have been mentioned on the survey that perhaps could be thrown into the ring for our QI awards this year. So looking ahead at 2023, we do anticipate sending out the inventory surveys again in July or August. We will give everyone plenty of time to respond and send plenty of reminders. We know that summer is busy with vacations, so we want to give you plenty of time to respond to the surveys. And we would really love your input on new questions to add to the survey this year. So what would you like to know about your peers and your colleagues' stroke programs? If you have ideas off the top of your head, feel free to post them in the chat, or you can always email me. My email address is on the slide there. You could also email that general health.stroke inbox as well. So that's all I have on our inventory surveys, and I'm just going to end with a little bit of evaluation housekeeping. We wanted to remind you that, as Nikki mentioned, our monthly education series videos are posted on YouTube. We are also including the link to the REDCap evaluation survey in the YouTube description for these videos. And you can take those surveys at any time and get that certificate of learning to get those contact hours for your participation. Your responses to these surveys also really help us, keep track of how we're doing with these series and get ideas for future topics. So just a reminder that you can find those links on YouTube. So that's all we have for you today. Thank you all so much for participating. If you have any questions for either myself or for Nikki, please throw them into the chat. And I will also share that evaluation link for this month's survey in a moment. And I think I will turn it over. Oh, Michelle's got that link. Awesome. Thank you.
Thanks, Mimi. Yeah, we can just wait a moment here. If anybody has any questions, feel free to unmute yourself or go ahead and type them into the chat.
It looks like we have a raised hand from Brian. I'm not sure, Michelle or Nikki in WebEx.
Can you guys hear me?
Yes, go ahead.
Okay. So I'm kind of new to my position and diving into the more administrative side. And I work at a thrombectomy capable stroke center. What category would that be that you guys are referring to? Because I know we're not complex, but would we acute stroke ready? Because when you guys listed them all before, I didn't see TSC. I just saw primary or complex.
Yeah, that's a great question, Brian, and thank you for asking. We currently, the way the legislation is written is for comprehensive, primary, and acute stroke ready hospitals. What we have done, and you work at Essentia Health St. Mary's in Duluth, correct?
Correct.
Okay, yeah, so on our website, we do have an asterisk next to Essentia Health St. Mary's, and it indicates that you guys are a thrombectomy capable stroke center. So we do have you clumped under the primary stroke center certification level presently.
Okay.
Thanks for that question. Anybody else at the moment? All right, so we're just about at time. If anybody thinks of anything, please don't hesitate to reach out to me or my team here at MDH. Again, thank you for joining us. I did not send out a monthly update this month because we have our program update here today. So in our follow-up email, stay tuned for that. We're going to include some of our newer resources and highlight some information in the follow-up email for this webinar. Thanks for joining again. Take care, everyone, and we'll see you in February for Heart Month.
Thank you.